Okay, today we're going to talk about what I think is chapter 17 of valvular heart disease. There we go. So there's some vocab that we need to go over and a couple of things. So chordae tendineae, they're attached to the mitral and tricuspid valves. They provide stability, and this will become important when we talk about stenosis and regurgitation of these valves. And then S1 and S2, these are the lub-dub sounds that you would normally hear when you're auscultating heart sounds. S1 is the mitral and tricuspid closing, and then S2 are the aortic and pulmonic closing. And then you have your S3 and your S4. So these are not normal noises. And I have a little graph down here if you can see my mouse. Here's S3. It occurs right after S2, and then S4 occurs right before S1. So S3 is vibration of blood flow against the ventricle walls. It's normal for children and young adults, but it's a sign of heart failure in older adults. And then S4 is the left atrium contracts against stiff left ventricles. So that one's definitely not normal. That can be a sign of hypertrophy and stiffness and some other bad things. And then we have two types of heart murmurs. So we have pathological and physiological. Pathological are like heart abnormalities, and then physiological are innocent heart murmurs that occur during stress, pregnancy, anxiety, or fear. They're intermittent, they're not all the time, and they do not cause any symptoms. Our next slide is valvular dysfunction. And before we kind of get into like the nitty-gritty of this chapter, it's super important to know which valves are what. So make sure you know those kind of before going over this chapter, because knowing especially what side of the heart they're on and where those valves lead to, like atrium to ventricle or ventricle to pulmonary vein, that is pretty important for this chapter. So valvular dysfunction. So there's two causes of valvular dysfunction: stenosis and regurgitant. And basically this whole chapter just goes over all four valves, stenosis and regurgitant, and then what they cause. So stenosis is a narrowing, or it does not open completely. Let's see if I can, yeah. So this thickened ventricle wall, the aortic valve can't open completely because of the hypertrophy of your ventricle wall. And then regurgitant is the valve does not close properly, and there's going to be leakage and backflow back into the ventricle or atrium, whatever it might be. Then there's going to be some hemodynamic changes that valvular dysfunction causes. So it's going to cause turbulence. So I kind of made this little, there we go. Where blood flow should normally go like this, but then if it doesn't flow right, it can't flow straight, and it's going to kind of bounce off the walls of your blood vessels, of your atriums, and your ventricles, and that's going to cause some damage to the endothelial lining. There can be excess volume left in the chamber, and this can cause some backup into your pulmonary edema. It can cause peripheral edema because everything just gets backed up, and there's excess hydrostatic pressure that is there, and then it's less efficient. So if you can't push all that blood out, you have to push that much more blood out each time, and your ventricles and your atria have to work that much harder. And then obviously you're going to have some left ventricular hypertrophy is kind of what this picture is showing you here. Diagnosis and treatment. The book just gives you a big old list. And you can do an echocardiography. This is the gold standard. This is kind of what everybody is like, yes, this is what you should do. Transthoracic, non-invasive. It uses sound waves on your chest to produce images of the interior of your heart. Transesophageal, the patient is sedated for this one, and they go down your esophagus to get a kind of a better visual of what your heart is because you're that much closer. A Doppler echocardiography measures the velocity of blood flow and shows abnormal blood flow. You can do this during exercise or just in a regular echocardiography. And then valve stress is going to be exercise. And then coronary computed tomography. So this is going to use contrast dye to give a 3D picture of the moving heart. And it's also going to show some of your bigger coronary vessels as well, which can be important, especially if you're looking for things like ischemia and stuff like that. And then some treatments. So there's surgical valvular replacement and transcatheter valvular replacement. They're the same thing. It's just kind of different on what they do. So surgical valvular, you're going to have a little incision made in your chest, and it's going to be pretty invasive. And then transcatheter, they're going to go in your femoral artery, and they're going to weave that all the way up to your heart, and they're going to put the valve in with the catheter, and your old valve is going to stay there. And then I'm going to mess up this word here. Percutaneous, maybe, balloon valvoplasty. So they're going to insert a balloon into the stenotic or hardened valve, and they're going to blow it up to see if they can unharden it, I guess. Valvotomy is just going to reshape your heart valve. And then bioprosthetic valve, I didn't put it on here because it didn't fit, but artificial valve, these are literally replacing your valves. Bioprosthetic is going to be from a pig or a cow. That's going to need to be replaced in 10 to 15 years. And there's artificial mechanical, which is, like it says, mechanical pieces that are not, they're not biological at all. So they're going to be metal or plastic. I didn't do a ton of research on that. They last a lifetime, but they can be a spot for thrombosis for blood clots. Now we get into kind of the nitty gritty of it, of all the diseases. So first up is mitral stenosis. And kind of the most important thing to remember here is stenosis is hardening of the valve. If you remember that and you know where the valves are, you're golden for this chapter. And then insufficiency or regurgitation is where it pushes it back, but then some leaks through. So in mitral stenosis, the mitral valve is thickened, fibrotic, and narrowed. A murmur is heard when blood attempts to squeeze past the stiff valve into the left ventricle, and it's best heard at the apex. And this is kind of a bad representation, but if you can see, I have a plastic bag. So let me get it in the view. So let's say this is your blood, right? And with stenosis, the blood can't get through because that valve is thickened. So it has a harder time getting through because the valve won't let it get through as well. And then eventually it's going to back up into your pulmonary veins. It's going to cause pulmonary edema, fluid accumulates around your alveoli, and you're going to have impaired perfusion and gas exchange. And it also causes left atrium enlargement because the left atrium, right here, if you can see my mouse, has to work that much harder to pump the blood through the mitral valve. And I think that, especially with this chapter, if you know where your valves are, you can kind of not guess, but you can kind of surmise what atrium or ventricle is going to have some enlargement because they have to work harder or they have to do XYZ, and it kind of all connects, especially with your, what did we talk about in the last one? It must have been atrial disorder, something like that. And if there's any sort of backup from your your left atrium, you're going to have some pulmonary edema. If there's backup in your right atrium, you're going to have peripheral edema because it can't, take the blood. So it all connects, I promise, somehow it does connect. Next is mitral insufficiency or regurgitation. There's two types, primary and secondary. Primary is an abnormality with your mitral valve, and secondary is due to ischemia, so muscle death, of your papillary muscles. They rupture, which holds the chordae tendineae, and then those help that mitral valve stabilize it. So if those rupture, obviously you're not going to do so well. Eventually, your mitral valve is going to fail to close completely. Blood is going to back up in your left atrium, again, causing pulmonary edema. Anything left side is going to pretty much cause pulmonary edema. And then a little extra side note that wasn't stenosis or insufficiency was your mitral annular calcification. This is like a calcium develops on the rim of the valve. It allows for regurgitation because that valve can't close all the way and it doesn't completely empty. And then mitral valve prolapse. So the mitral valve is going to be floppy and loose. It allows blood to flow back into the left atrium, and it lowers the amount of blood that flows to the aorta because your blood is normally this mitral valve would stop it, but if it's floppy, the blood can flow back, and so there's not as much blood to pump back into that aorta to get it out to the body. Severe mitral valve prolapse can cause coronary insufficiency, which causes ischemia. So then you're going to have angina pectoris, some dyspnea, stuff like that. Next is aortic stenosis. So the aortic valve is calcified, it's hardened, it's narrowed. And then left ventricular flow is obstructed. So you can kind of see this, my mouse here. Right atrium, mitral valve is good, but now we have a hardened aortic valve, and this is eventually like the picture really shows. It's going to cause it's going to cause left ventricular hypertrophy, and eventually ischemia because again your coronary supply can't produce enough blood for the hypertrophy that's coming along in your left ventricle. And then hypertrophic cardiomyopathy. Large left ventricle impedes blood flow to the mitral valve. So this is your muscle wall is going to get so thick that your valves can't open and close properly. Then we have aortic insufficiency regurgitation. This is going to be incomplete closure of the aortic valve, causes leaking of blood back into left ventricle, and can eventually cause a backup into the pulmonary veins. Again, anything back up into the pulmonary veins is going to cause pulmonary edema, impaired perfusion, impaired gas exchange. It all goes together. Next, we have pulmonic stenosis. There we go. Pulmonic stenosis and pulmonic insufficiency. So this is narrowing of the pulmonic valve. It's not going to be able to, the blood isn't going to be able to get through well enough. It's going to have to work harder. Okay, I know where I am, sorry. And then pulmonic insufficiency, regurgitation. The pulmonary valve does not close all the way. It allows blood to flow back into the right ventricle, backwards pressure into the vena cava and venous system. The symptoms of this are going to be similar to right-sided heart failure because obviously it's the same side of your heart and it's going to eventually probably cause right-sided heart failure. So you're going to have jugular vein distension, edema in the ankles, peripheral edema, same thing with the tricuspid because you're not able to pump as much blood and your right atrium is going to have to work that much harder. It's going to become hypertrophied, all that fun stuff. Last one is going to be tricuspid stenosis and tricuspid regurgitation. So, tricuspid stenosis is a narrowing of the tricuspid valve. I know it's crazy. We've talked about it like 4 times. This one's usually caused by infectious endocarditis due to illicit IV drug use. And the book kind of talked about this, that when rheumatic fever was a big deal, lots of valvular diseases were caused by rheumatic fever, and they were kind of like a sequel to it. Now that that's kind of under control, we don't really see that in the United States as much, but we see it a lot in India and actually in China, which is kind of interesting. But now that we kind of have less outbreaks of that, we don't see that very much. It's usually caused by other things like infectious endocarditis. And then your tricuspid regurgitation, the loose tricuspid valve allows blood to flow back into the right atrium, causing right ventricular failure because your right ventricle has to work so much harder. It's going to become hypertrophied, all that fun stuff. And your regurgitation is going to cause increased hydrostatic pressure into the superior vena cava, and it's going to cause peripheral edema. So this one was kind of redundant, but once you know the definitions of stenosis and regurgitation, and if you know where those valves are, if you know where your atriums are, you're pretty much golden for this chapter. There's a lot to read in the book. Don't get caught up in all of the etiology, how it's treated. I made a big list of how you treat it and how you find it. It's just a point of knowing where your valves are and knowing what stenosis versus regurgitation and what ventricles they're going to affect, and then what system they're going to affect. Because if it's on your left side, you're probably going to affect that pulmonary system. You're going to affect your lungs. You're going to have some pulmonary edema. If it's on the right side, it's going to affect your body systems because that blood is being pulled from your body versus from your lungs. So, alrighty, thank you.